Thank you. And before we turn to Kevin Hudson and Steve Ruberg, we have a question from the audience.
This question is from David Lawton. Nursing's role in health IT has generally been focused on acute care and to some extent on office and clinical care. Are any of the panelists involved in helping patients obtain copies of their medical records, including both cost and benefits data? So we should probably refer that to the provider, the nurses that work for provider entities here on the phone. Certainly, if you don't...
Can you reread the last part of the question, please?
Certainly. Are any of the panelists involved in helping patients obtain copies of their medical records, including both cost and benefit data?
Okay, so at Kaiser Permanente, right, the massive focus is on inpatient but also outpatient. Our business is actually larger on the outpatient side of the house than the inpatient, and if we keep them well, that'll continue that way, and that's what we hope to do. But also looking at different care transitions to hospice care and other areas. When it goes to outpatient, and as far as, if I'm understanding the question correctly, getting access to one's data, how do they collect that and get that? From the EHR perspective, in the previous days, I'll call them the olden days at Kaiser now, to get copies of your paper record, it was quite easy. You paid a fee, or an agency came in and copied those things, and out you go with it, and you're good to go. We had some struggles initially as we were getting to know and optimize our EHR product, in that when we would get requests for copies of members' files, getting them out of the system initially was not that easy. We'd print them out, and we had 200 pages, the medical file, and a quarter of the page maybe had information. It's just scattered all over the place. So a lot of programming challenges and fine-tuning there. But yes, we are able to get that, and I'm not exactly getting the cost part of the question, but they're being in the system, being able to get it out, it does save costs, because we can solicit or hone down, display what we're after, rather than copying and furnishing the entire medical record.
Thank you, Curtis. If I could jump in as well, as a nurse within a provider organization, certainly the act of release of information is something that's managed by the health information management professionals. You can do that once and then move the information into a personal health record for the individual. And then in terms of benefits and cost, certainly, there's lots of aggregated data on, CMS, Hospital Compare, that type of thing. But there's also a complete shift in the mindset. It used to be that your wellness reminders would kick off when the patient scheduled a visit, showed up, and the physician or the nurse taking care of that patient opened up the electronic health record within the provider exam room. And what we've been trying to do is to actually take all of those wellness reminders and push them out to the personal health record, because if the patient does not have a outpatient visit during the time that they need their seasonal flu shot, then they will not ever get that reminder triggered. And so there's certainly very much an emphasis on moving provider records into personal health records at the request of the patient, and then empowering them with that information.
The last two speakers were Curtis Dikes and Linda Fischetti, our moderator. Curtis, I think the questioner may have been asking how can they get cost data in the medical record when requested now.
How can they get the patient themselves? I think that can be done I believe that can be done and requested. It would be contacting the appropriate office, and probably through member services. The way that our plan works, it's a prepaid, it's a HMO plan. So though we do have deductible HMO products, and which makes us more competitive against some of the other insurers out there now that have lower rates and perhaps lower benefits to their plans, what happens is that our members pay a deductible for their care, or a monthly premium and then a variable deductible. So we can break down costs, and those can be furnished. And with our various deductible plans now, patients will either pay co-pays and or get bills for that.
Thank you. Kevin Hutchinson.
Well, I'm thrilled that the nursing community is here because my mother-in-law is a nurse, my sister-in-law is a nurse, and they're both in Boston, Mount Auburn Hospital, and there is not a family event that goes by that nurses are very passionate, I will say that. And I am reminded on a regular occasion of the important role of nursing as we go down this path of health IT, so I'm thrilled that you're here today. A question, and this is maybe a theoretical, kind of a day in the life of nursing. I'd like to know kind of a compare and contrast between the role of nurses in their day-to-day duties prior to a health IT going into either a hospital and also particularly physician practices, and then the role of the nurse post kind of a health IT. Because I can imagine that you were dealing with data before computers, even in a paper record environment. Maybe we didn't call it nursing informatics, or maybe we did, but I'm curious what, if any, role change that you've seen of the nursing skill pre-automation and post.
So tremendous change, and I'll start with this and then hand it off quickly. Tremendous change in the way that nursing, even from a cultural perspective, where was information? Information was in a paper chart, and whoever had the chart was king, right? And everybody else was waiting. So you could only get to that was the Bible of the patient's information. The other thing was information transpired often at the nurse's station, sort of a hub and spoke thing. When somebody left, they traveled around the unit. They may have the chart, they may not, but nothing really, people didn't talk to each other until they got back to the unit. Or it may be in the break room where people often went to chart and kind of conversed and exchanged information in that way. So that being before. Today, in the electronic world, a lot of institutions, including ours, use what are called wireless cards. So they're a computer on wheels that a nurse and or provider takes with them when they visit a patient's room, and they have access to that chart. It's with them all the time. And they can pull up all sorts of things. I mentioned physician documentation, nursing documentation, and other disciplines. There is a great ability with the EHR to display what information you're after, to digest it or look at different views. And as you saw in the short commercial I shared with you, just as that patient can look and trend what their lab values were, the nurse can do that with eyes and O's or lab values or different medications. So it's much more powerful. When we think about HIT, often the EHR comes up, and it's a big part, and it's very important these days, but there are other technical health informatics type of systems that are also very remarkable and helpful in practice. Unified communication devices, common brands are Vocera or Cisco phones. So what that does is, rather than, who has the narcotic keys, because there's, for safety, one person's carrying the keys and you trade it off between nurses. And so it's yelling through the hall or going and finding everybody. Hunting and gathering doesn't work well. So using a device, instead of waiting until I go from the back of the unit and see my patient and come back to that nurse's station to exchange information or even get a phone call or page somebody, I can use these robust technologies to get information anywhere. If that's, yes.
I just want to give an example about having access to evidence.
Both
Victoria
Curtis,
Bradley.
Exactly. Thank
Sorry. And that was Curtis. So as a nurse, I remember that you can't remember everything. So I do not know what every drug that's going to be ordered is for, or maybe what the side effects are. But now, instead of looking for that paper PDR that was well-worn and who knows where it is, I immediately have access. So if you tell me you're on a little pink heart pill, I can look it up and see if that's what it is this the medicine that you're on? Or if I'm seeing these signs and symptoms, I can look that medicine up, right at my, like you said, right at the bedside, and see if these are some of the signs and symptoms that this patient is presenting with. I could be on a unit, maybe I haven't taken care of a total hip for a long time, so I can, again, immediately look at the plan of care, what is the best evidence, and how should you care for a patient that's had a total hip. And so it's immediately there for me to see. So I think having that information, because if somebody tells you they know it all, you know that they're dangerous, because you can't in today's field. And so you can have those resources embedded in the EMR or immediately available to you.
Thank you so much. Oh, Rosemary? Sure.
I just wanted to add one comment and dimension to that perspective in terms of the change of culture from being a nurse directly providing care for a patient in this world of informatics. I think that there's a certain amount, we're seeing the generational gap a little bit. I'm 49 years old, and there are times, even when I practiced a year ago, after 20 years of HIT, when IT would walk into a patient's room, I'd tell them to leave because I would be concerned about what they were doing with the device while I was providing care. But then a new generation coming out of school that are expecting it and could probably actually design it. To that extent, Tiger, which Joyce mentioned, Technology Informatics Guiding Educational Reform, is really looking at developing a workforce that's capable and has the basic understanding of some principles, so they can take those principles and merge them with what they know about patient care and data in order to improve the delivery of healthcare. So really collaborating across, because we need to do a lot of that education if we're going to accelerate the adoption of the technology. Also, just one other point, in my prior world, I spent a lot of time implementing, and we asked the nurses what they wanted in the system and how the system should work and everything, and every other word was the system or the electronic health record. We then did a pilot, and we went in and talked to the nurses about evidence-based practice and what they wanted and how they wanted to practice. And all they kept talking about was HIT and technology. So we had a better source of requirements going in under the umbrella of what do you need to provide good nursing care and patient-centered care. And we said, well, we're not here to talk about technology. We're here to talk about evidence-based guidelines. And then they called us on the phone. They said, we have a wonderful template that we just built. And I thought, oh, dear, HIT gave them sign-ons. Now we have, 2,000 nurses using the EHR to build the system. But they designed it in a Word document. So they actually were able to do that translation between the data and the information that they need for care and how they kind of wanted it served up to them.
And very briefly, and I know this will shock you, but I'm going to give you a physician's perspective on this. At the Institute of Medicine opportunity on Monday, a physician spoke about they had just implemented an EHR at their organization 14 months ago. And he said what it has transformed not only his practice, but the practice of all clinicians, because now their conversations are focused on what's really important, because they know from the chart or from the medical record that what the medications are, so they don't have to spend time talking about that. They know what the lab results are and the other reports are, because that's easily available to everybody at all times. Now they can talk about what's really important.
Excellent comments. The last two speakers were Rosemary Kennedy and Joyce Sensmeier. We're now going to turn, before we turn to Steve Ruberg and Lori Evans, to another question from our audience.